my name is Noah. I'm a senior here studying psychology and global health. And I am talking about my thesis research, which is for distinction in psychology and global health both. So my presentation may be a little different than the ones to come. I decided not to do like a really formal research presentation, but to really talk about kind of like getting started in research and like what kind of prompted this interest and how I got really involved. So as I said, I'm studying psychology and global health, and I started taking classes in both my freshman year. I realized that I was really interested in like the methods and kind of the means of global health. I really liked working with diverse populations and like the ethical training and everything like that, but I was more interested in the concepts of psychology. So I was specifically interested in abnormal psychology and psychopathology. And so I was looking for a way to kind of marry my two interests, and it kind of came to fruition in global mental health research. And so, like any eager undergraduate, I sent out a ton of emails to try to get involved in research, and was lucky enough to connect with Dr. Puffer and Dr. Nicole Heilbrunn, who works at Duke IPMH. And IPMH was running a couple different studies, but one of the programs that I was specifically interested in was looking specifically at Latino mental health in Durham, and they were also looking at emergency department data. And so what we knew is that, or what I did for them was kind of during my junior year was completed a needs assessment and literature review that focused specifically on Latino mental health in Durham County. So I compiled a lot of previously completed needs assessments and kind of put forth this report to them, and then I was looking for a way to push it forward. And so they said that I could look at the emergency department data. I decided to compare different diagnoses and the percentage or prevalence of diagnoses by ethnicity. And so my research question was, what can be learned about the experience of racial and ethnic minority children and adolescents from emergency department data? And so with the emergency department data, I had access to age, sex, race, ethnicity, and then the ICD-10 CM diagnostic codes, which basically is just a set of codes that's a grouping for psychiatric diagnoses. And so I looked at every person age 18 and under that presented to the Duke Emergency Department and was given a psychiatric primary diagnosis. And here's a graph that kind of compares what I found by non-Hispanic or Latino white, non-Hispanic or Latino black, and Hispanic or Latino. So just generally, and I'll explain more about the different codes later, you'll see that there are some pretty interesting disparities in like what each population was diagnosed with. And so my main findings, I compared using two sample t-tests and found that overall, the diagnostic profile of Hispanic and Latino children was more similar to that of non-Hispanic and Latino whites than that of African American children, which was really interesting and something that I didn't expect because I kind of expected the shared minority status to play into both of them. But there were significant differences in the percentages of specific diagnoses, specifically between Latinos and non-Hispanic or Latino African Americans. For one, non-Hispanic, and then also within non-Hispanic white and black populations. And so I found that black populations were significantly more likely to be diagnosed with mood disorders and behavioral and emotional disorders, with things such as ADHD. And then they were significantly less likely to be diagnosed with substance abuse disorders. However, Latino populations were significantly more likely to be diagnosed with substance abuse disorders and less likely to be diagnosed with behavioral and emotional disorders. So one of the coolest things that I found about my project was that I knew that whenever I finished my project, like whenever I did my needs assessment and literature review, the team at IPMH, even though I was just an undergrad, they were more than willing to like disseminate my findings for me. And so whenever I prepared the manuscript, they sent it out to everyone within the department and were like, oh, look at this cool work that Noah's doing, which was awesome. And so that'll be one of the next steps after I finish my thesis, is for them hopefully to share it out. And then, although I am graduating, like I envision a follow-up would be like a qualitative or mixed method study to really understand why and kind of what reasons are driving the disparities that we see. So I'm sure we'll come back for questions later, and I think I'm passing it off to Allie.
I'm going to try to follow Noah's really good clicker usage. Oh, yeah, that's me. So I'm Giusto. I'm a PhD student in clinical psychology. I work with Dr. COHORT, there's Eve, and I'm a doctoral scholar with the Global Health Institute. And so I'm catch my breath. I'm a fourth-year student of 5 years in the PhD program, so that means I've been working and thinking about my dissertation a lot. So a couple more years thinking about research. So I'm going to talk to you a little bit about that work and present some interesting pieces going forward that I thought we could focus on given our time. So for my dissertation, what I hope to do is to develop and pilot a brief intervention to reduce problem drinking and increase family involvement among alcohol-using fathers in Kenya. Kind of an interesting piece. Kind of why I want to do this is for a couple reasons. Alcohol use in and of itself is very problematic, and it disproportionately affects men across the board and has a lot of physical, well-being consequences and consequences for mental health. What we also know, particularly men's alcohol use, has these huge ripple effects across the family system. So at the family level itself, and then within the systems there. So it's associated with intimate partner violence, problems co-parenting, marital conflict, ineffective discipline, child maltreatment, and impacts child mental health and well-being on both the physical and mental levels. That's what kind of got me really interested in this, is a piece that we're missing that's really impacting the whole family system and going on to impact child mental health. Further, we also know that in low income and low resource communities, this kind of exacerbates the risk across the board. And then we have this added factor of gender norms across really all societies, but the more men are in positions of power, these ripple effects might be even more pronounced. So holding a lot of decision-making power, financial power. So it might be really important to engage them in intervention. What we also know is there are no interventions targeting this intersection of risk. Despite men's alcohol use and these family-related problems being so intertwined, there aren't really any good interventions that have been looked at in low middle income countries that are targeting this intersection, despite their kind of overlap. And there are, I should note, there are a few in high-income countries, but they're pretty long, arduous, and a little bit complicated to train on. So what I hoped to do for my dissertation, what I hope to do, I wish I've already done it, but is to develop an intervention for these alcohol-using fathers. So men who we know are in families and are experiencing problem drinking. Then I want to look at its feasibility, acceptability. Does it work? Can we do it? Can we train on it? And then look a little more closely if we're able to change things like alcohol use and men's family-directed behavior. So that could be anywhere from increased parenting support or even working more for the family. And then secondarily, trying to see if we'd see any kind of ripple effects, distal impacts on family functioning, individual mental health across the family, and potentially other engagement and available services in the community. So I'm hoping to do this, and I will be doing this in Eldoret, Kenya, and that's where a lot of the intervention has been based on in previous work in this area. Just briefly about the methods, I really won't go into this much at all. The intervention development was multi-step, systematic, and mixed methods, and I'm going to talk a little bit more about that because that's what we've done the most work on. Next, we're going to do a process evaluation, mixed methods approach again to look at acceptability, feasibility, and then we're going to use an N of 1 design to evaluate these intervention-related outcomes, so alcohol use, family-directed behaviors, and I'm happy to talk about that more in the question portion. So I think one of the most interesting pieces and the pieces we've thought about the most is what we're going to do to kind of reduce this alcohol use and maybe engage these men more in their families, and how those two things can work together synergistically to both reduce and improve outcomes. So from qualitative data, from review of the existing evidence, we've identified a few strategies and begun this intervention development. So we identified motivational interviewing, behavioral activation, and some gender transformative approaches as kind of the core basis for the intervention that we've integrated into 4 sessions. Right now they're a little bit long. They'll be about 60 to 90 minutes that will initially pilot and then collaboratively and iteratively change in country and with in-country partners. So I'm just gonna tell you a little bit briefly about the mechanisms of these interventions will kind of remain the same. So motivational interviewing is all about increasing readiness to change, finding reasons for change and why you'd want to change. So we can think about with a dad, a family focus, maybe a reason to change is to be respected more in the family, to be a better father, even something like to have more sex. That can be a reason to change related to the family. Then with behavioral activation, we would work to increase activities around those reasons for change and values associated with those. So then we can think about my reason to change to be a good dad, my value is to be a respected father, I'm gonna do more activities in line with that to begin to replace the reinforcement you're getting from drinking with these healthy alternative behaviors. And this has been shown to be effective, BA, MI, for alcohol use and other mental health problems in low-resourced communities. Lastly, and a really, I think, interesting piece I'm really passionate about are these gender transformative approaches, and that's a really fancy name for saying discussion about masculinity. So adding a brief component about what does it mean to be a man? What does it mean to be a father? What was your dad like? Intergenerational models of parenting, and can we include ideas of nurturance and care into those ideas of masculinity and manliness? And the idea around that is to reduce stigma around treatment engagement and increase engagement and motivation overall. This is a brief, not brief, a big change. What's it called? Diagram, but I'm not going to go into right now. And very briefly, I think some of the interesting potential implications to this work is, can we have unique impacts on the family system if we can engage men, and is that really helping these men's mental health overall, and eventually these intergenerational cycles of risk, can we learn and where can we break those? So that's it for now. Happy to take questions later, and I will pass it over.
Glad to be here. I'm going to try my best to do this in 7 minutes. I'm going to talk a little bit about task shifting programs, and this is research that I came into in my doctoral program and even before, but have really been thankful to continue to do this work as a postdoc, working with Melissa Watt and Kathy Sikkema here at the DGHI. I started here in the fall and will be here for 2 years, so I'm really enjoying the work so far. So my question that kind of drives most of my research is this question of, where does mental health treatment, or where does mental wellness, where is it fostered, where does it occur? And historically, in developed countries, it started off in places like hospitals, in outpatient therapy rooms, and in schools. But I think in countries where the mental health system isn't as well developed, it offers these new opportunities to kind of flip that on its head and say, just because that's how it developed in countries where it's been around for 150 years, does that mean we need to do the same things in other countries by developing it in the same places, in the same ways? So this person at the bottom is Nado, my good friend in Philadelphia. She is a refugee health worker who supports caseworkers in a community health center. So her background is as a nurse in Burma, in Myanmar. She came to the United States with limited English, limited training, and found it challenging to kind of get into school to become a nurse here. She had this opportunity to support caseworkers, social workers in the refugee community in Philadelphia and take on a caseload there, and has just thrived in that role. She's there with some elders from the community. She single-handedly formed a group for elders to get together within the community center And some of these elders, since coming to the United States, felt completely trapped within their homes because they felt like without English, without a good social network, there was no reason to leave the home. So they ended up being kind of within the home, just being, staying with their families, and are now out in the community, thriving, learning English, learning the culture in a way that many of their predecessors never did. So what is task shifting? It's simply the delivery of care by non-professionals. It's a way of us saying that rather than looking at care or mental health from a top-down way, of saying that those who are experts are able to deliver it to the community, that we can kind of take that task and allow others to kind of take it on. So these can be community health workers, which is a fancy term for saying people who have no training in mental health at all and kind of building that up. People who are professionals in other areas, such as nurses or teachers, or teaching family members to kind of be advocates within their family group or within their community to kind of offer some of these things. It's being advocated as a way to address treatment gaps, or the mental health gap, which is this huge disproportion in between the number of providers available in a lot of contexts and the problems that we face. So by teaching others who haven't traditionally provided that care to provide it, we're able to address that gap. Here's a demonstration of how that can look in action. And so this is a project we did in Haiti where, as you can see, 13 kind of leaders at the top of this triangle, supervisors and coordinators. These are the people who kind of had a lot of previous training. We're able to train 96 community health workers, called agents here, and each of them served 160 families each. So 15,000 families, or 70,000 people, are essentially being served by these 13 people at the top, who are then kind of training the community health workers. So with a little bit of resources, you can meet the needs of a lot of people. So what are the characteristics of kind of a good task shifting or good community health worker program? I put this in intentionally knowing it would drive the quantitative folks in the room crazy, but you know it when you see it in some ways. And that's true of a lot of participatory action and kind of community-based programs, that when you go there, you can almost feel it in the air, feel it in the water, that there's a different kind of horizontal power structure. The conversations are happening in a way where people feel empowered to kind of speak up and talk about things. And our challenge as academics, as researchers, is finding a way to quantify this, right? But there is an aspect of just kind of knowing it when you see it, that these things like access for everybody within the community, achieving the goals of the program, this way of kind of first doing no harm, or kind of making sure that you're not unintentionally causing negative outcomes in the community. These things come through good participatory programs, but in some ways you can just kind of know it when you see it. So one example of the work that we're doing around task shifting happens in schools in Tanzania. So we're looking at ways of saying, how do we build guidance and counseling from the ground up in Tanzania schools? There simply aren't school psychologists, aren't guidance counselors, and in a school like this with very few resources, it's a really hard sell to say, you should hire a school counselor. You should hire a school psychologist. It's simply just not going to happen because of the lack of resources for simple things like books, right? And so what we can do is say, can we take one of your teachers for a training and give them some important skills around guidance and counseling, and then they'll kind of take on that task in addition to their regular teaching duties. They'll be also a social support for your students. And when we make that pitch, people are happy to take us up on it, because it essentially costs them nothing and is a great service for their students. In the refugee community in Philadelphia, almost invariably these people have struggled through some sort of trauma. And we know from kind of the textbook, from what the goals of kind of recovering from trauma are. And that trauma can occur at any point, either before they resettle, during resettlement, or even after resettlement, as through the difficulty of acculturation. And we simply can ask ourselves the question of, are these goals best met by a caseworker who doesn't speak the language, has not been through that experience, and is fairly unfamiliar with the experiences these people have gone through? Or is it best served by somebody who's a member of the community and is continuing to face some of the same stresses of acculturation? And again, it's a pretty easy answer that those case aides like Knettel tend to do this much better than people who are from outside the community. An exciting part of this is that I've been able to continue some of these projects as I've taken on this role as a postdoc here at DGHI, so that's been outstanding. And it's also been really exciting to be able to kind of adapt some of my previous work around task shifting in some current projects that I'm doing with Dr. Watt and Dr. Sikama. So for the ones where we're already kind of in that intervention stage, there are already kind of task shifting at play, that we're taking people who maybe don't have formal training as mental health providers and having them offer the interventions. And then for those who are at a little earlier stage, we're given the opportunity to kind of think about interventions that may involve some sort of task shifting down the road. Just want to end with a little bit about resilience, and kind of task shifting and this community-based approach to research I think go hand in hand, that it's a way of, again, kind of taking that power structure of the historical people who provided and received care and flattening it out to say we're all kind of members of the same kind of, we all have the same goals in trying to kind of improve mental health and well-being in communities. And so it's a way of kind of taking away what used to be more of a deficit-based approach. Identify problem, treat problem, and instead saying that we're trying to build a capacity that's already there, in this case resilience. This is one of the elders again from the Myanmar community in Philadelphia, and we call her our poster child, which she thinks is hilarious because she's in her 70s. And she's one of those perfect examples of somebody who was shut in. She was with her family and that's about it. And after 5 years in the United States, finally had opportunity to kind of join this elder group, come out of her shell, work with the caseworker, and has really just thrived, and is now kind of working with textiles in the community, coming to ESL programs, and just often there. So, so I'll just end on that note.
Hi, my name is Yujung Choi, and I'm a second-year master's student in global health, and this work that I'll be presenting today is part of my master's thesis with DGHI. So over 2 million kids under 15 are living with HIV, and most they don't know that they have it, and they begin intraretroviral therapy without knowing why. So our goal was to develop a survey assessment tool to measure caregivers' readiness to disclose to their child about their child's HIV status, so that the support can be tailored to the specific needs of their child's caregivers. In order to develop the survey instrument, to compile the survey items, we conducted a formative qualitative study involving focus group discussions with people who are generally involved in the disclosure process, like health workers and caregivers who are of HIV-positive children and adolescents living with HIV. And we were able to validate, we were trying to validate a survey instrument through a 3-wave panel through the prospective cohort study. So the work that I'll be presenting today is it was the results of the first baseline survey results. So in Biki Tanzaka district of Zimbabwe, here, we were able to randomly sample 400 caregivers who are taking care of children living with HIV, who are between the ages of 9 and 15 and are on antiretroviral therapy. And we had a 93% response rate in the first wave. So this was conducted last summer. So we were able to figure out which caregivers disclosed to their child and which caregivers hadn't disclosed. And just last month, we completed a second wave of surveys. We followed those who hadn't disclosed from the first wave. In looking forward in the third wave, we will be looking at those who hadn't disclosed and who had disclosed from the second wave. So of the people who were surveyed in the very first round of surveys, about 2/3 of children know that they have HIV, that they have a condition called HIV, but they don't know all the details about it. And we consider full disclosure to be when children know that they have a condition, chronic condition called HIV, and that they know how they acquired it, and that they can spread the infection to other people. So only about a quarter of kids know that they know all these information and are considered fully disclosed. And here we have a map of Zaka and Bikita districts of prevalence of kids who know that they have a condition called HIV. The darker the shade of blue, the greater the disclosure rate. So you can see that disclosure rate varies across clinics. So of the people, 372 people who are surveyed, 30 kids don't know anything about their illness. They don't know that they have a chronic condition that requires ongoing treatment. So these are people who are considered to be in the non-disclosure group. 93 kids know that they are sick, but they don't know that they have a condition called HIV. And of the people who know that they have a condition called HIV, some people know how they only know that they know how it was acquired to them, how they acquired it, and there are some people who only know that how they can transmit it to other people, and 54 people know that they only know that the name of the illness is HIV. So dashed lines over here are what's categorizing partial disclosure. And again, like I said, about a quarter of the kids who are surveyed were fully disclosed, knowing all these information about their HIV status. So those who didn't know that they have a condition called HIV were the ones who are followed in the future panels here. So of the people who know that they have a condition called HIV, typically they found out this information when they were 10, and how they found out this information kind of varied. So about 3 out of 5 kids found out from their caregivers, 2 out of 5 kids found out from other people besides caregivers, like a health worker or another family member. And most caregivers thought that the disclosure experience was positive and perceived that after disclosure, their child's medication adherence to medication improved. Caregivers tend to worry that disclosure will lead to their child not taking their medication and having less adherence. And it looks like, according to our study, following disclosure, kids tend to do better with their adherence to medication. So looking at the rest of our future goals and studies, we're going to be collecting data from all 3 panels, and we want to test our conceptual model of a disclosure process. So these are concepts that are incorporated from the health beliefs model and include concepts like caregivers' assessment of risks and benefits, their subjective norms, and their sense of self-efficacy, which all lead to readiness to disclose. And this is the part before disclosure is what we're interested in improving in the future. But we're also interested in looking at what happens after disclosure. So what are the consequences? So we're trying to look at child's mental health and physical health and how they relate to the adherence to their medication. That's it. Thank you.
Allie, I actually have one for you.
Imagine being single.
So Allie, I was wondering, so you're using an N of 1 design, which is not something typically used in psychological research these days. How did you investigate alternative methods and think about how to use alternative research methods based on your setting, which can be limiting?
Very good question. Well, I think I'll start this with the caveat of I think it's a product of getting to work with Dr. Puffer and a product of global mental health. This like confluence of factors. I get to pilot an intervention for my dissertation. Like, how cool is that? But what and how can I do this feasibly in a setting with however many resources you can get, and trying to do that rigorously too. So how sad would it be to go to Kenya? I did all this work, and it's meaningless because I wasn't able to look at things in a rigorous enough way. So that's where the N of 1 has been really interesting, and luckily people have started to do it in global mental health previous to me or things our lab has been thinking about, as a way to kind of get around that. So I don't need to do an RCT, this huge trial, recruit all these people. Maybe there's a way that I can recruit one person, so that's my N of 1, my sample of 1, and measure them really rigorously and examine these factors really rigorously around my model and my question to be able to look at the mechanisms I think will work. So a step back is that an N of 1 design is basically, we might think of it as a case study, so you recruit one person, but the way you're measuring those outcomes might look a little bit differently. So when we think about a case study, that's really qualitative. I'm describing what I think happened in treatment, but the easiest way for me to think about an N of 1 design is almost like an interrupted time series. So I'm gonna do a lot of repeated measures at baseline, so I have this person's control group within themselves. I have this behavior drinking across, let's say, 2 months if I had enough money to measure that and could incentivize people to do that measurements. And then I start this intervention and I keep measuring alcohol use. I withdraw my intervention, I keep measuring alcohol use. I can say a little more clearly that when I introduced X, my intervention, we saw a change, or saw no change across their own control group and after withdrawal. So it allows you to look at causality a little more rigorously only with one person, and you can create different parameters to make that more or less rigorous. So if I add 2 more people and I'm measuring in the same way and all of their alcohol use goes down right when I introduce the intervention across time, I can say, okay, I've repeated this across 2 other people. I can now say even more clearly, we think X caused Y, without doing a whole randomized controlled trial. So it's a nice way to pool and get a small sample and test a new treatment, and that you can adapt for the person. So that was a really long answer too. It's short, you don't need to use that many people, it's clinically indicated, and it makes a lot of sense for trying new interventions.
Any questions from the group?
Hello, I'm Jason. This question is for Noah. I was wondering if you could give some details about the data you found about the emergency services regarding Latino population in Durham.
Yeah. So I more generally on my findings, or how I got access to the data, or
both.
Both. Okay. Okay. So when I connected with Nicole Hilburn at IPMH, they were running lots of different studies, and I kind of was lucky enough that she was like, oh, whatever you're interested in, just let us know and we can try to work you in. And so they had already pulled the emergency department data for an existing study, and so it was easy. I did the online city trainings and everything, signed papers and everything like that, and they were like, well, you can have access to this if you work here. And so I did that. It is a de-identified data set, so there are no issues with confidentiality or anything like that. And so that's sort of how I got access to it. And then I ran 2 sample t-tests to compare. Basically, I pulled the percentages within each population or ethnic group, and then compared between ethnic groups. And so I knew that roughly 20% of Hispanic or Latino patients were diagnosed with substance abuse disorders, but roughly 3% of the African American population that presented to the Duke Emergency Department was diagnosed with a substance abuse disorder. And so I just found kind of interesting findings like that. What prompted me initially was through doing the like literature assessment or literature review and needs assessment, I kind of expected to see hyperprevalences of substance abuse in Latino populations as well as anxiety disorders. But then once I kind of like dug around in the data more, I realized that there were even other findings that I wasn't expecting, and that there was even some really interesting data within, especially like comparing between non-Latino white and non-Latino black. That was really interesting that I wasn't even trying to go for originally, but ended up being something really worthwhile to look at.
Thank you.
Yeah, thank you.
Hi, I have a question that I'll direct towards Yujung. I wonder if you could talk about any sort of lessons learned from working on a global mental health practice in a country that was, I assume, very new to you, and sort of just a little more what that fieldwork experience was like and what you learned, and then maybe related to that, any lessons learned that you would advise students regarding working with a mentorship team.
Okay. Yeah, so I guess I'll answer the second part first and then go from there. So yes, it was my first time doing research abroad. So I was with 7 local Zimbabwean women who were running the surveys, conducting the surveys in Shona, which is the local language in Zimbabwe. So I was always spending time with them for 7 weeks. We ran surveys 6 days a week. So we were always going to a clinic, very involved. So it was very different. You have to think about, as somebody who's not, I wanted to be culturally sensitive first, so I didn't want to be the 4th person that somebody sees in the first place. So when these participants come, I wanted them to see the local enumerators or the CHASAs, which are the community health workers that we also worked with. So I did a lot of behind the scenes work, working on tablets, fixing problems if there were any. What else? So my work was mostly working with the local enumerators and also talking with my advisor on any of the problems that needed to be addressed to make sure that the survey goes smoothly. I think the one lesson that I learned from the experience is really not unique to this cultural aspect. It was more about me learning about how to work with people in a small group of settings, but with somebody that I work with every day, every second for those 7 weeks. So it was hard to be in that environment because before going there, I was very used to not having that close connection with people, but I appreciated it because that meant that we were able to talk about problems right then and fix the problems right then. So we also had debrief sessions where we talked about what went well, what didn't go well every 2 weeks or so. So I think that helped as well.
Yeah, that's great. I don't know if anybody else on the panel wants to add to lessons they've learned.
Yeah, I would say, you know, I kind of talked about being in several different contexts, and I think the general lesson that I've always taken from each is learn before you ever kind of hope to teach or instill anything. And so the first several weeks or several months in a lot of cases are just really formative for me, and just trying to kind of get immersed as much as possible and learn as much as I can from folks. And that happens over days and weeks, but certainly over years as well, that as you become more familiar with the context, you maybe feel more empowered to kind of step up and represent that context, if that makes sense. But it takes a lot of time.
I'll just add a quick note. You reminded me when you're saying talking in, or being in close quarters, you never know what your working conditions will be like, but being self-aware and keeping in your head the things that, maybe because I'm a mental health, that make you really anxious or that make you really uncomfortable. always kind of have those in your head to know and prepare yourself. Okay, today might be a hard day, and just having a little self-awareness and thinking about what you're bringing in your own, what makes you, even if it's something that every day makes you uncomfortable, that might be highlighted. I think that exercise can be helpful in knowing when it's
Questions for Brandon. In your task sharing work, how have you drawn the boundary that stops you from assigning too many tasks to someone who already has a full-time role in the community?
Yeah, that's a really excellent question, especially in a lot of cases where people are volunteers or asked to be volunteers. In Haiti, the program was initially designed so that all of the community health workers were volunteers. And we quickly learned exactly how much they were sacrificing in order to support other people in their community. Not the least of which they were traveling 16 kilometers on average by foot for most of them to even attend our trainings. And so oftentimes they were staying locally with, friends or family, and so they were away from their families for a week or 2 weeks just to attend the training to become a community health worker. Huge burden on them. And so one of our first recommendations in the evaluation we did there was to pay these folks, please. Like, they're doing this incredible amount of work, and we're dedicating all these resources to go there and provide training. And the budget deserves to have payment so that these people are getting remuneration for their work. So that's one part. But I think just in general too, seeking perspective, that through our interviews with them, we quickly learned the burden that was being placed upon them, and then we could kind of scale it up or scale it back, or add more community health workers once we had the data to kind of show how stressful some of this was. As a provider myself, I think it was easy for me to see that burnout that comes with empathy and kind of seeing the difficult stories of so many people. And if I feel burnt out after seeing 16 patients in a week, imagine these people with 120 families on their caseload and how heavy that burden must be. And so I think just trying to incorporate a lot of compassion and empathy for the difficulty that they're facing.
So you guys are all at different stages in your education. I was wondering if you could take just a second to talk about how you got where you are and where you kind of see yourself moving from here.
So how I got here, I guess. So I applied, and it was the best day of my life. But then I guess kind of to lead me to research was really just like being open to experience and really just like seeking what you want to get out of it, I guess. And so there's a lot of opportunities, I guess, at Duke that are available to a lot of people. You just have to be willing to go ask for it, or try to involve yourself. And I would say it's pretty likely that someone will be willing to take you in. And so I guess I got here through lots of like asking and great mentorship and everything. And then what happens next? I'm working for a couple years. I love this question as a senior. Working for a couple years, and then hopefully applying to graduate school.
Can you say what your position will be next?
I'm working at RTI International, doing like public health program evaluation work.
Okay, so I began to be interested in global health because I grew up in Korea and in the States, and I've worked with North Korean refugees, and that's what kind of drove me I was gravitated towards studying something international. I think that was the goal at the time when I was in college. So I have a degree in international political economy, but I quickly learned that global diplomacy is not something that I wanted to do. I wanted some more tangible skills. So I got involved in learning about taking science courses, and with the hope that I will someday be somehow involved in medicine, global medicine. So after I graduated, I worked for a bit, and I was enrolled in a post-baccalaureate pre-med program to take the science courses. And I applied to the Global Health Master's program here, which is how I'm here now. So in looking forward, hopefully I will get into med school. I don't know how else to say it. I'm not saying it bluntly. I'm waiting to hear back. Yeah, for this fall. But hopefully in the long term, like my future goal would be to somehow get involved in medical research and practice medicine and see patients. Yeah.
I'll try. Brandon, make sure I'm short, okay? I'm giving you this response. I really related to the comment that Noah made, that the means and the methods, you really latched on to that in global mental health, and I think I'm a person that really felt the same way, like the methodology, kind of the ethos, and how work is done, and the kind of spirit behind that was how I had approached and thought about my work in psychology prior to coming to graduate school, and when I was applying to graduate school, what I was looking for, and I can tell you a little bit about that, but I think that for me made a lot of sense and was definitely a bridge into this. But in undergrad, I was really interested in psychology, but I thought I wanted to be a teacher in early childhood education, a really cool program. And through that, I got really interested in preventative interventions, community-based interventions, participatory research, mostly through the clinical side and seeing little kids in the real world and their parents and kind of the tough situations they were facing, and feeling like, oh man, I worked at like an inpatient unit in one of the schools and seeing the same kids come in over and over because parents couldn't afford care or they were in foster homes, kind of seeing the reality. I felt like, oh, these kids like don't even have a chance. Got me really interested more in the social emotional development, preventative interventions, and then after graduation, doing more of the research side. So I worked as a research assistant 1 year at a cancer hospital, and then 2 years I worked at a nonprofit and with University of Colorado Boulder and their psych department on a community-based project. And I was like, oh, I love this. I love doing the clinical work, seeing how that informs research, and then asking research questions related to that work and getting to be involved in the dissemination and implementation of it. Just so happened, you does really cool and similar work around community-based methods, intervention development, thinking about people and communities and how to best reach the most amount of people in the most effective ways. So I hadn't done I didn't even know global mental health was a thing until I was applying to schools and seeing that all the things I was really drawn to fell into this bucket. And kind of that's what drew me to grad school and led me to apply and go the PhD route. And I'm happy to talk about PhD versus master's programs if anyone wants to after too.
Yeah, and for me, I think it was a really a stepwise kind of growth, that I came from a really small white rural community in the middle of Minnesota, and just in undergrad kind of had the opportunity to finally see perspectives that were very different from what I had come from, and kind of did a toe in the water study abroad trip to Australia, and then from there to Tanzania and there to Haiti. And so it kind of was a cascade, right? It kind of built up momentum of just learning to look beyond what I had kind of grown up with and known. And so I felt really fortunate to have all the opportunities along the way, and to be able to kind of expand my horizons gradually based on where I came from, and especially still looking back at folks who never left. It's been a pretty incredible journey for me. As far as next steps, I do hope to apply for faculty positions in the near future, kind of continuing to do what I'm doing here.
Thank you, guys. So as Eve alluded to, global mental health is a really growing field, and it's such an exciting time to be involved in it. And this event was put on in part by the DGHI Faculty Global Mental Health Working Group, and also we have a newly established Student Global Mental Health Working Group, which is being supported by the, I had to write this down, Duke Center for International Global Studies. So if any of the students in the room are interested in learning more about global mental health or would like to be involved in future activities like this, you can come up and see Emily and I after we finish. Give a round of applause.